Can we restart? There we go. Thank you.
So we use lasers in our practice very often to make our scars look better. So this is somebody I did Mohs on and did a linear closure, and a couple treatments of fractional ablative erbium fortunately made things look better. Still having problems with this. So this is something that we do commonly, and when we're treating patients with a laser from a surgical perspective, I think that's easy for us to explain. When we're treating patients who've had a complication from a laser in the past, and we're using a laser to treat that, that's a different story. So from a surgical perspective, this is a young girl who had a failed rhinoplasty. She required a forehead flap, and with multiple sessions of non-ablative fractional lasers, non-ablative lasers, drizzling over the area with ablative fractional laser and laser-assisted drug delivery, she got better. And I continued to treat her, so that picture was after 10 treatments at her 11th visit. So this is a similar situation. This is a patient who had a facelift. She had bilateral flap necrosis on both cheeks. This was the more prominent side. And over the course of, you can see, 10 years, we were able to make things look better. I'm going to address the post-inflammatory hypopigmentation and the pigment loss in just a second. So this is a patient who, for some reason, didn't pursue laser tattoo removal. Instead, they actually went back to the laser salon and they injected lactic acid into the area, causing these hypertrophic scars. So I did pulse dye laser, non-ablative fractional, and drizzled and injected these areas for laser-assisted drug delivery just to make things better. And then we talked to her about laser tattoo removal. But I spend a fair amount of my time in practice doing heavy resurfacing, many times full field erbium, and I'll discuss my experience in terms of many of these are my complications. So first, with full field erbium, I feel better about much less chance of having pigment loss, and a lot of times people want to see pictures of patients years later, and this is 3 years and 5 years later. But obviously potential adverse events definitely happen, and post-inflammatory hyperpigmentation is definitely a real concern, especially with non-compliance. Shortly after doing resurfacing on this patient, she went on a kayak trip and she ended up getting a lot of sun. This is a patient who actually swore up and down that she was going to wear sunscreen. She was an avid golfer. You can see it was winter time when I did this and the ski transitioning season, but she ended up finding time to play golf and didn't wear her sunscreen, and this hyperpigmentation then became my problem. I think she had a good result of improving her lines and wrinkles. Sometimes we look at pictures and wonder if it's hypopigmentation ahead of time or if it's hypopigmentation afterwards. But I would argue that in some cases there's some actinic-induced hypopigmentation. So this patient definitely has some cobblestone appearance and elastosis on the initial photo. I think her lines and wrinkles are better on the post. Sorry about the lipstick in the post, but you can see that cobblestone and pigment loss from actinic damage is better. And here, in terms of the left chin, I'm not sure what's going on, but I think that her lines and wrinkles definitely look better from heavy resurfacing, and she was happy with that result. There could be a little bit of hypopigmentation. I think that's very different than over the years people saw CO2, full field CO2 induced hypopigmentation. This is a patient I saw not too long ago that had had that treatment many years ago and came to try to improve this, and we'll talk about that in a second. But it can happen with ablative fractional. This is ablative fractional CO2 that I inherited this patient, and you can see a few things were probably done. Number one, I think that there was overlap, even though this was fractional. The overlap is where she has pigment loss. And two, for some reason, they have a very, very definitive area of a cutoff instead of blending this area on the cheek. So whether it's the laser itself, as some of the suggestions here would point to over the past couple days with some studies looking at laser-assisted drug delivery, or it's bimatoprost with the laser, I don't know, but after a series of some laser sessions with this patient, I think you can see the repigmentation. This was another circumstance of somebody who'd had fractional CO2, too high a settings, overlap, and an undesirable result, and we made things a bit better using either the non-ablative fractional or the non-ablative fractional plus bimatoprost. exactly the same situation here. It was fractional ablative erbium. Joe Weibels actually showed that ablative may actually lead to a bit better result. And another circumstance here, this patient was a picker in terms of acne and healed with some hypopigmentation. So infection, as many people have shown, are always questions. Obviously, we need to look out for a pre-existing infection, but these are all circumstances that I caused these infections right here. So this patient took acyclovir after I resurfaced her. Acyclovir doesn't have the bioavailability that Valtrex, valcyclovir, and famciclovir have, and now that those are generic, I use that instead. This patient, I did a non-ablative fractional. I've never seen this before, but I caused this HSV reactivation. And now based on that, I actually ask patients a lot more frequently about this. This is a patient that I had a Mohs reconstruction. I think all of us people that do Mohs get concerned when we're in the philtrum area. And in the philtrum here, I was thinking about a lot of things, including Cupid's bow, but I never asked her about HSV, and she ended up having a whopping HSV. So I try to ask patients when I'm doing procedures around the mouth. Resurfacing is obviously something that is very different. We're concerned about that. This patient just didn't finish her course of Valtrex, so she stopped it after 5 days. And you can see she ended up having HSV in that picture here. And I'll point to it. I don't know. I'm going to skip that. Other non-compliance issues, I always tell patients just use white petrolatum or one of our post-procedure formulations that don't have antibiotics in it. For some reason, this patient used polysporin and then came in. We looked at her, we cultured, we did a KOH, and I put her on diflucan, and then 2 days later, she sent me a selfie, and she ended up having little bumps, and that she came in and we cultured, and that was Staph aureus. So I don't know why patients just don't use what we tell them to use. Our instructions are very clear. It says don't use Neosporin. This patient used Neosporin on her chest after some resurfacing there. You can see a whopping contact dermatitis that became my issue afterwards. Patient went to something that they'd used for many years, but when it's abraded skin, you have a much more significant antigen load and the immunogenicity on that area. And then always be on the lookout for infection. I resurfaced this lady's face, her neck, and her chest, but I definitely did not resurface her shoulder. I came to the phone when there was some distribution complaints of the shoulder. We had her come in, but oftentimes if you see, because this is itchy, people end up scratching it, and you see some linear areas, and this was Staph aureus. This is a patient who had been on a cruise 10 weeks before, came to me just before her granddaughter's wedding and wanted to resurface. She was on cough suppressant. I didn't ask about a cough, and turns out she ended up having a pretty whopping infection. So many of these things can happen, and I'll end up with eruptive keratoacanthomas. This is a circumstance where a colleague actually saw this patient resurface them, and you can see 3 circled areas. They ended up biopsying it. The biopsy was positive for eruptive keratoacanthomas. I've seen this in a patient who fell on the ice. This has been described with non-ablative fractional, ablative resurfacing, many traumas, different surgeries. This has been described even after photodynamic therapy, and I recently saw this. But for this case, I would have left this alone, and I would have followed this patient sequentially, and this is what I do now. This patient had a very similar picture, and I just followed her every day or two until it resolved, and I think that's probably a good place to stop. Thanks.
Thanks, Joel.